Our speaker this evening is Sampada Deshpande, DDS, FACD. She practices in the Bay Area. Due to her specialized training, she is consistently approached for care by patients with special health care needs and/or medical complexities. Author of the book Persevering, Sampada earned a DDS from the University of Washington and completed a GPR at Alameda Health System. Sampada lectures nationally on treating patients with special healthcare needs in a private practice setting and using portable dentistry. Her writing on this topic and others has been featured in the American Dental Association, Academy of General Dentistry, and Dental Ergonomics. She's currently building a family first practice in San Carlos, which will also offer sedation services for those who require it. She lives with her husband and daughter in the Bay Area and is expecting their son in January 2026. Welcome, Dr. Deshpande.
All right. Hi, everyone. I am very excited to be here and to meet all of you in person. I am hoping for this presentation to be as interactive as possible. So stop me at any time and I'll ask questions. In the middle, we have some case studies in the presentation. So hopefully it's a lot of fun and you get a lot of value out of it and you're able to use it in practice tomorrow or on Monday. Yeah. But my name is Sampada, and this is a topic on special care dentistry. It includes dentistry for patients with special healthcare needs, as well as really any medical complexity. So we'll talk about everything today. Of course, we have just an hour, so it's not possible to go into too much detail. So if you have questions, we can talk about it afterwards as well. Okay. So of course, before we begin disclosure, the presentation has been made possible because of Pattison. And my purpose here is to just provide accurate as well as timely information that will help you increase access to care. I see a lot of specialist friends here, and hopefully this is of value to you as well. A little bit about myself before I dive in. I graduated from a dental school in India. I was born and raised in Dubai and went to India for my dental school, finished in 2013. Then I moved to the US, finished dental school again at the University of Washington in Seattle, and that was in 2018. After that, I was practicing in Seattle for a few years. And I was enjoying dentistry, but I wasn't really feeling it. It was just, I felt like something was missing. And after a lot of reflection, I realized that I'm actually not seeing patients with special healthcare needs, which was a passion that I realized I had at that time. And I'm so glad I kind of listened to myself, because that persuaded me to do something called a LEND training program. It stands for Leadership and Education in Neurodevelopmental Disabilities. So it's a program that's actually offered in like 52 schools across the country. It started from the time of like JFK. So it's been around for a long, long time. And it trains professionals like ourselves, as well as school teachers, self-advocates, lots of other different kinds of professionals on how to work with people with special healthcare needs and how to kind of engage with them and just live life with them. So that kind of totally changed my understanding. And after that, I realized I need to go back to school and do a GPR so that I get the clinical skills necessary to see this patient population. And Alameda Health System is right here. It's in Oakland. A year over there taught me a lot of things. It's just a chaotic place. If any of you have heard of Highland Hospital, you kind of know what I mean. And that's just a picture with my daughter. She's about 2 now. And that's me lecturing at the Washington AGD up in Seattle. So currently I offer at home or in facility portable dentistry. So believe it or not, I go with 2 of my assistants. We take all of our equipment on wheels, literally, and we go bedside to a patient's home and offer them dental services there. So the only thing we really can't do is root canals, obviously, and implants. But we do a lot of extractions, we do fillings, crowns. It's hard work, ergonomically very challenging, but we have ways of getting things done. I'll kind of go over that in the middle of the presentation. Most of my patients are either people with special healthcare needs or pretty medically complex. And in the case studies, we'll kind of go over, what kinds of patients these are. And we receive referrals from either general dentists or physicians, some of them who are in geriatric medicine, who are seeing our patients in practice and want the patient to see a dentist who can come to their home. So it ends up being that we are a very small network of people who provide home services. So we tend to kind of know each other and make referrals to each other. But that's my website if you ever have a question about that. All right, so we'll jump kind of right in. We'll talk about a few things today. We'll just kind of go over the definition of what special care dentistry is, because that's kind of important. Clinical presentation, as well as medical considerations. And I'll kind of go over some of the most common things. I can't go over every single thing because there's so much, right? But I'll go over the most common stuff that you'll see. I'll talk about behavior and environment, how you can kind of try to manage those behaviors or modify the environment in your dental office to help our patients. And then we'll go over the business side of things, administrative. I've noticed that a lot of my colleagues tend to have hesitation around the business side of stuff. How do you make it, flow in the practice? What does insurance look like? So we'll go over that. And then we'll go over emergencies as well as sedation, operating room dentistry, what that kind of looks like, and whether or at what point you should be making referrals, right? Okay. So this is the definition that was actually put forward by the American Academy for Pediatric Dentistry many years ago, and it's still very, very valid. If you can see, there's a lot of red in it. But basically what that means is that a lot of the definition is really, really important. It tells you that somebody might be born with a special healthcare need, but a lot of people are actually not born with special healthcare needs. They acquire it later on in their lives. So there might be someone in your practice right now who has been completely neurotypical for 20, 30 years. And now at the age of 50 or 55, they require specialized services. They require more accommodations at your practice. And you're starting to notice maybe there's a cognitive decline. You might be the first to figure that out. Nobody else knows about it. You might be realizing that, oh, they're having trouble like driving to the office now, and maybe we need to help them. Or you're starting to notice that their oral hygiene is suddenly slipping. Like, why? They were fine for so long and now it's not okay. So you could actually be the person who discovers this, and that is so crucial to know, that we have that ability to actually make that alert in the medical system. But basically anyone with special healthcare needs finds themselves having difficulty in maintaining regular activities. So like going to the bathroom, making a meal for themselves, brushing their teeth. These are the things that they're having limitations with for a variety of reasons. So we'll go over some of those in just a bit. Just FYI, I'm sure most of you know this, we no longer say stuff like special needs patient or autistic patient. I know it happens, and sometimes I find myself saying that, but then you have to stop yourself. So it's always person first language. So person with special healthcare needs, or a person on the autism spectrum. That's just a more kind of respectful way, and it seems to be the language that most patients with special healthcare needs like to go by. There might be individual differences. So who are these patients? They could be anyone. And simply by looking at the person, you might not know that they have a need that you need to be aware of. That's kind of the most important thing here. So the way we find out as their dentist is by giving them the questionnaire and having them tick mark that, oh, I need an accommodation, or I have this particular need. It could be IDD. So IDD is intellectual or developmental disability. It could be any kind of physical disability. So someone who's coming into your office on a wheelchair. It could be ASD, autism spectrum disorder, ADHD, or ADD. These are also considered special healthcare needs. Of course, there's Down syndrome, cerebral palsy, dementia, or Alzheimer's. Anyone who is medically complex. So by medically complex, I mean they're on a lot of medications. They have maybe 10 medications that they're on, and they have lots of chronic medical conditions that are being actively managed. And then we have, of course, behavioral or sensory disorders, as well as most of our geriatric patients typically tend to be in this category. So maybe someone comes to your mind who you were thinking, oh, they are, completely neurotypical. This is not a patient with special healthcare needs, but actually they might fall into one of these buckets. So they are a person with special healthcare needs, and we have to be offering them certain accommodations when they come into our office. And why should all of this matter to you, right? Most of you are extremely busy, Dennis. You have a busy schedule. You have, your teams to take care of, and you're in the middle of doing crowns, implants, and everything is, I'm assuming all of you are very, very busy. And why should we learn about this? Of course, the most important reason really is access to care. We all know that most of our patients with special healthcare needs are being referred in big populations to the hospital. We have just a few hospitals taking care of most of our patients in the Bay Area. There's Highland Hospital in Oakland, there's Stanford, and then there's 2 hospitals in San Francisco. Many of their GPR programs are being shut down for a variety of reasons. So when we send patients out to the hospital, either they're waiting a long, long time to be seen, or they're not getting seen at all, and they're getting pushed into another hospital system where they will again wait. When I did my residency, I have seen patients, I would see them at the beginning of residency for a consult. Then by the time that treatment came, I was almost about to graduate. So they had waited almost a whole year with nothing being done. It was really sad. So the access to care crisis is real, and it's kind of unacceptable. When patients are waiting that long, typically like little problems like small cavities are obviously getting really big. So by the time they're seen in the OR, now we have to take teeth out. And it's really sad when we start taking teeth out, because it's very hard for compliance and other issues to kind of give them a partial or a denture. So that's not a possibility for many of them. So that's a problem. There's definitely a caregiver strain. So if we'll talk about it in one of my cases as well, but some patients will come with caregivers who are there to help them with their meals or going to the bathroom or all of these things. Many of them actually have not been educated on how to brush someone's teeth. And that is something only we can offer to them. We have to train the caregiver on how to brush somebody's teeth. And because I have a hygienist friend who actually explained this really nicely to me. She said teeth are sometimes invisible. When you talk to a patient, you might notice that their hair needs to be cut, or their nails need to be clipped, or they need to go and have a shower or something, or they need to change their clothes. But sometimes you might not see their teeth, because many patients are not very verbal and they're not talking the whole day. So teeth kind of tend to get forgotten. Even when someone's eating, they might not be opening their mouth big enough for you to actually see their teeth. So caregivers have no idea that, oh, I need to take this patient to the dentist. So there's a lot of strain on caregivers, because they're often shuttling these patients around to multiple appointments, and dentists kind of get forgotten about because other things come up. Of course, the few doctors who are taking care of these patients tend to get burnt out because they're seeing everyone. I have some patients who are scheduled months out because I just cannot get to them. And I have maybe 2 or 3 colleagues in the Bay Area who are seeing these patients. So it gets really hard, and patients get disappointed because obviously they want their care to be, taken care of. They want to be seen right away, but I can't do that. And I think the most important thing are these last 2 reasons why we really should care. These patients are some of the most rewarding and loyal patients you will find. Once they find you, and you do good work and you meet their needs, they will never leave you. and they will send everybody they know in their circle to your practice because they love you so much and they don't want you to leave. um, and of course the other reason is, as we all age, we all know Americans are living longer, and we know that people are retiring even later in life. They're living with more chronic medical conditions than before. So sooner or later we have to start taking care of these patients, even if we can't right now. We have to start seeing these patients. So that's kind of another reason. um, so what are some of their biggest barriers to care? There could be lots of barriers. Of course, the one that comes to our mind is the physical barrier, that there's like this wheelchair that most patients come in. Most patients now don't really have a traditional wheelchair. They have these giant kind of motorized wheelchairs. I call it like a mini car because it looks like a car. It can do like crazy things. It's huge, and it might not fit into your operatory. It might fit through the front doors, but it might not go into your operatory. So how do you see them in your office? I'll go over that in a minute. Um, the other thing is, many of these wheelchairs, they actually tilt back and can become a dental chair. So I have like two patients whose like the back actually tilts all the way 45 degrees or wherever we want it. And it's like, oh wow, this is great. This is like a dental chair. I can totally see you. Um, of course, there's communication. Some patients are nonverbal. How do you communicate with them? To mind, most of my patients who are nonverbal, either they have cerebral palsy or late stage dementia patients, where most of the communication is going to be nonverbal. And we will go over that as well. There's behaviors and sensory issues. I think somewhere down the slides, I have some behaviors listed, which are red flag behaviors. So if you see these behaviors in your office, I need you to look at safety first, not just for the patient, but also for your team and for yourself. So we have to know what our limitations are. Some patients should not be treated, and we have to do certain modifications to make sure that they're ready to accept treatment. So we'll talk about that as well. um, Sensory issues, the dental office in general can be a very overwhelming place, right? For most of us, right? There's a lot of noises, lots of new people, lots of crazy looking tools. If you try to process that as someone who's neurodiverse, it can be a lot. So we have to try and make things as easy as possible. I call it like the cockpit environment, where they literally come inside and they don't see a whole lot. It's just clean, and they basically just see the chair and they sit. If they start looking at all of the instruments laid out, you should cover it basically. If they start seeing all of that, it's going to like make them have a lot of questions and it's going to go south. um, and of course, I talked about caregiver burnout, so I won't go over that again. Insurance, the reason I have it listed last is because I feel like that's the position it should have. But insurance, I've noticed, is more of a barrier for us rather than the patient. Most patients do have insurance. You don't. I'm not going to encourage anyone to take state insurance or not take state insurance, or private insurance. But what I've found is most of the patients who come in, who are in this patient population, they value their oral hygiene and they value dental care and they want dental care. So if they find out that maybe you don't accept their insurance, or your business requirements are different, as long as they know that you are the dentist who can serve them, they will find resources that it takes to help pay for treatment. They will do that because they value the care they receive. Because again, there's not a lot of providers who do this work. There's just a few people. So if once they find you, they'll be like, okay, I will take care of it. Don't worry. But that conversation has to be had with the patient and their families. And we'll go over that about who these decision makers are in their family system. All right. I call this part of the presentation the meat and potatoes of the presentation. This is probably kind of the longest because it tends to be a little bit clinical. But I have some case studies here, so hopefully it's fun. But basically, we will go over some some conditions, some medical conditions. And if you have questions about it at the time, just stop me and ask those questions, okay? So this is me with my daughter at Special Olympics. Are any of you part of Special Olympics or volunteer? Do you guys know what Special Olympics is? Yes. So Special Olympics has a big summer event, and they have a fall event as well every year. It's always in Santa Clara for the last few years that I've been. And they have a clinic called Special Smiles, which is for the dental for the dental professionals. So Special Olympics is basically for people with special healthcare needs, for them to participate in lots of different sports, which helps create great self-esteem, helps them in engagement, and it's just a great way for them to stay healthy. And Special Smiles and Healthy Feet, there's like all of these different categories of healthcare professionals. We visit them the day before the sporting events. So when we visit them the day before, that's when they actually get educated about their teeth, about their feet, how to keep everything healthy. And it's just a really fun event. If you've never seen patients with special healthcare needs in your practice and you're really interested in it, I would suggest starting to volunteer. At Special Olympics, we are always looking for clinical volunteers. We always are short staffed. So if you have interest in that or becoming a clinical director, like the way I am, please reach out to me. I will be happy to get you started on this. But these are some of the conditions we'll talk about today. We'll talk about IDD, Down syndrome, cerebral palsy. I'll go over dementia, and then we'll spend some time going over some medical complexities. So any kind of intellectual or developmental disability is physically very indistinguishable, right? You might see a patient and just not know that they have any kind of intellectual or developmental disability. Maybe you might notice some changes when you start talking to them, but otherwise you might not know at all. So again, asking them the question on the medical questionnaire is what will reveal it, okay? A lot of patients with IDD tend to have something called polypharmacy. Does anyone know what polypharmacy is? Maybe you can kind of guess at it. Right. So you will often see not just patients with IDD, but just patients with special healthcare needs being on like a long list of medications, like 10, 15 medications. Unfortunately, many of them are additive, or like they kind of have the same mechanism of action. And that's because so many of us healthcare professionals are not necessarily communicating with each other's specialties. We all use different practice management softwares. Most of us don't use Epic. All the major hospital systems are on Epic. So we tend to add medications that we don't realize are already being taken by them. And this is a big problem. So it's something that we actively need to make sure of when we especially give out like benzodiazepines or something like that, any kind of sedative drug. We want to make sure that the physician hasn't put them on it first. I won't spend too much time on seizures. Seizures scares all of us, but most patients with seizures are pretty well managed with medication. I have yet to see in like the last 4 years that I've been doing this, someone who is actively like uncontrolled seizures. Like that's almost never happening. You might see a seizure and you have to kind of learn to manage that, but you will not see a lot of people who are not being maintained. Um, the high incidence of decay and gum disease that you see in this patient population has nothing to do with any genetic or any kind of predisposition that they have. It's usually either because of lack of access to care or because they're on a lot of medications that are causing xerostomia. These are really the reasons why you see any kind of decay or gum disease. And as a rule, I don't actually have them modify any medications that are causing xerostomia. I just help them counteract that because they're on those medications for a reason. So I'll tell them to like sip a lot of water, keep a Stanley cup or something with like a sippy cup, sip a lot of water, use a lot of mouth rinses. I usually don't recommend alcohol-based rinses. Have most of you heard of Stella Life? Stella Life is a product that's kind of homeopathy based. And it's worked really well for most of my patients, because many of our patients have very specific tastes, and alcohol tends to trigger things. So Stella Life has actually been really good. I have no disclosures. It's just a good product. Um, but we have them use that. AAC. So many of you have heard of Stephen Hawking's, right? He uses an AAC. So AAC is alternative and augmentative communication device. It could be of various types. It could be as simple as an iPad. Patients might come with an iPad or like a little book and write something because they're not speaking. So they write something and they show it to you, and then some of my patients, like I have a patient with ALS, and he has a device in front of him where he will look at the letters, and on the back of the device the word comes. So he will say, and he's very grammatically correct, so he will say, "Hi, exclamation mark, how are you today?" question mark. And that takes a long time for him to write, so I have to wait there for like 2 minutes till he finishes and then respond. Even though I kind of know what he's saying, I have to wait. But people can come with these devices. So this is an important thing for, again, the questionnaire to ask, or your scheduler, whoever's making the appointment. Hey, do you bring an AAC? Is there something we can provide for you in advance? Do you need an iPad, or do you need a book? We can keep that ready for you. Or if not, just bring whatever you need. So patients just need to be reminded, and so that the dentist and the team is not surprised about, what is this device that this patient is using to communicate. So now just remember, people use that. The biggest reason for you to see these patients in private practice is because you can offer them consistency, which a lot of hospital systems cannot offer. Most hospital systems have attendings that are coming on different days, and residents that are changing every year. So they will be seen by new providers pretty much every visit. Whereas in a dental practice, a private office, it's always going to be you. It's going to be your hygienist, your assistants. They're not changing a whole lot. Patients really love that. If they see the same team, they actually perform much better. One of my case studies goes over that, how just the familiarity that got built allowed the patient to do so much better at subsequent visits versus the first visit. So we'll go into that. Down syndrome, most of you are pretty familiar with this, but it's caused by trisomy 21. The biggest thing with patients with Down syndrome to remember is most of them have had some kind of cardiac surgery in the first few years of their life or at birth. So many of them are seeing a cardiologist pretty much annually just for a consultation, even if they are very well managed. But because of this reason, if you were to ever send them for sedation or operating room dentistry, you always have to get a cardio consult. So you have to send a consultation to make sure that everything with the heart is okay before they go. Unfortunately, many patients with Down syndrome also tend to develop weight issues. You'll see a lot of patients being overweight or being in the obese category. If you start to see that, then you have to automatically think that this patient is a possible risk for obstructive sleep apnea. If patients are a risk for obstructive sleep apnea, typically they are not going to get qualified for hospital dentistry, because anesthesiologists will look at the patient and say, no. I've actually seen anesthesiologists kind of give us like the googly eyes at residency programs, where they're like, what were you even thinking? Why is this patient here? Because this is for a dental cleaning, and then we have to kind of explain that no, it's not just a dental cleaning. The patient needs this, and it's great value to the patient. But to them, dental always ranks last, because cardiac comes first, and lots of other conditions, neuro, like brain tumors, these things come first. So if anesthesiologists decide that this patient is too high risk because of obstructive sleep apnea, because of an aspiration risk, they're going to reject the case. And when they reject, this patient is coming back to your office, and now they're upset because they're like, you told me I can get dentistry in the hospital, but I can't go there. They said no. So in order to avoid this issue, I would say try and figure out in your private office if this patient is going to get declined. So if you haven't heard of the Stop Bank questionnaire, which is for obstructive sleep apnea, you don't have to be an expert in sleep apnea, just know what to look for. Those patients are typically not getting accepted for sedation or hospital dentistry. So just kind of keep that in mind. Um, a lot of patients with Down syndrome unfortunately also tend to develop cognitive declines early in life. There is a link between Down syndrome and dementia. So many of these patients will not be good candidates for any kind of benzo. I know benzo is what we do for oral sedation to get a bit of better compliance in our offices. Most of us use some kind of oral conscious sedation. Patients with dementia or who are at risk of developing dementia, we don't offer benzos to them. It will make their cognitive decline worse. So it's very frustrating as a provider when you can't offer anything that can help patients. I have seen some patients with Down syndrome being given SSRIs by their physicians to help with compliance. But even though I have seen that, there's not like a whole lot of difference. I will tell you that very, very frankly when I see patients like that. What really helps again is consistency and behavior management and influencing behavior change over time. But trying to do frequent recalls will really help with patients with Down syndrome, just to maintain their OHI. And some could be candidates for ortho, but again, their OHI has to be amazing. Their oral hygiene has to be amazing before you send them out to our orthodontists. And you have to be realistic with families about replacing teeth as well. Okay, we're making progress. Cerebral palsy. So I know some of you might have already seen patients with cerebral palsy, probably back in dental school or maybe in your clinic. But if you've noticed, a lot of patients with cerebral palsy will typically be wearing a big bib. They always have a bib in front of them because they're drooling all the time. Many patients with cerebral palsy are getting tube fed. They're not eating by the mouth. So when you open their mouth, you see a lot of tartar. Again, it's the invisible thing that one of my hygienist friends told me. Because we are concentrating on so many other issues with patients with cerebral palsy, we forget the mouth. They're not taking food by the mouth. So no one opens it to take a look. When you open it, you're surprised and shocked by how much tartar you see. Cleaning out that tartar is not impossible. It's possible, but you have to make sure that the patient doesn't aspirate anything. So like literally assistant has to be like here and you're cleaning like very close by. You have to make sure of that. But using an ultrasonic is the only way. You cannot hand scale these patients because the tartar is just so much. Airway management, again, that is everything is related to the feeding difficulty. And of course, relying on caregivers. Most of these patients that I'm mentioning come with some kind of support system. Either it's family members or it's a full-time caregiver. Use them. They are so useful and they're a wealth of resources. They have so much information about the patient. Definitely utilize them. Dementia. Unfortunately, I don't know if it's just me, but there have been some documented trends that are showing that patients are developing dementia much earlier now. In the past 10 years ago, it used to be around 60, 70. Now we're seeing around 50 and 60. So it's becoming that you're starting to see more younger, like chronologically younger patients developing dementia. And again, these kinds of declines are something that you can discover as their dentist. I'm just going to take a little water. Are any of you seeing do any of you have any patients with dementia? Yes. Okay. Yeah. 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 Um, That's actually so tricky, because I know HIPAA makes it so difficult to communicate with other people around them. But sometimes even just talking to them about it can be very helpful. I would highly encourage you or recommend that you kind of have a chat with them about, hey, how has life been outside of dentistry, like getting to the car, park, like driving, are you making your way easily to where you need to go, or what. Just ask them if they've had like brain fog. Yeah. Yeah, it can be so tricky, and especially like decision, when it comes to decision making is when it gets the hardest, because sometimes you want to make sure that they have understood, especially as dentists, our biggest thing is, do they understand the treatment plan? Do they know what they're signing up for? Do they understand why they are declining this? Because sometimes they will say, no, 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 I don't want anything, but those things are important, whatever you're recommending. So this can be very tricky. What is also more tricky is that a lot of patients, unfortunately, develop dementia and they haven't made any plans as to who their decision maker is going to be. And then once you develop dementia, you can't really give decision making capacity to somebody else because you no longer have that capacity. Um, so I think in the next slide, I will talk a little bit about geriatric patients and go over some advice there. But um, asking patients when they are at their best is really great. Asking caregivers, a lot of patients with dementia will not want to see you as their dentist if you're a brand new person. They do not want you to be there near them. So if you're seeing a new patient and you're confused about how to provide care, have them bring a family member. They should always have someone familiar to them in the operatory before you treat them. That will make a huge, huge difference. Um, Planning partials and dentures for patients with dementia gets super, super tricky because they might forget them, they might lose them, and then the family gets upset, patients get upset. It's a whole thing. So I would recommend having, you know how in pediatric offices we used to say like there has to be a tripod of decision making. It's you, it's the family, it's the patient. Sometimes it has to be like that. You have to discuss it with caregivers and families about giving them partials and dentures, because most likely they are not going to be taking care of it by themselves. They will have someone help them. So this is kind of the protocol that physicians follow. It's called the 5 M's, which is really, really nice. And they are supposed to be looking at these 5 M's at every visit with a patient who is 65 and up. Okay. Now, even though I say 65 and up, know that that's just a chronological age. If you feel like your patient is not quite where they were before they reach 65, you should be implementing these 5 M's previously. So the first M is medication. You're looking for all of their medications, making sure that there is no polypharmacy. The big takeaway for dentists here is if you are recommending a sedative medication or a pain medication, I typically try not to prescribe any of these. I actually have the primary care physician do it, because most likely the primary care physician has the full list of medications that I don't have, right? And I don't want to create any issues. So I have the primary care physician prescribe meds. So that's number one. The other thing is mentation, where you're assessing for delirium, depression, decision-making capacity in your patients. Medical comorbidities, uh, understanding the pathophysiology of stuff. And for dentists, how is this patient's diabetes? We were having a conversation about diabetes when we drove here, but how is their diabetes or their osteoporosis or their hypertension or stroke from last year? How is it going to affect my dental treatment today? That's what we really should know. What matters most? My last case study is about a patient who just wanted to have good teeth. She had a lot of other stuff going on. She was on a DNR status. Does anyone know what DNR stands for? Do not resuscitate. So She had already made plans that if, God forbid, but something were to happen, she did not want to live. She has already, taken care of her assets and her life, but she just wanted good teeth because she wants to be able to FaceTime with her grandkids. She wants to be able to talk to her friends. That's all she really wanted. And that was her most important goal. And mobility. Mobility is very, very, very important because a lot of our patients have a risk of falling, especially if they are starting to develop cognitive declines. Um, I received a question in one of my other lectures about what we do if we were trying to transfer patients. Transferring patients from a wheelchair to a dental chair is really tricky. The patient can fall, and more than that, it could be an injury, not just for the patient, for yourself and for your team. A trained professional should be doing that. So as a rule, I don't try and get into transfers, and I wouldn't recommend that to anyone. There's actually waivers and things in California. Your team needs to sign them. You would need to sign them if you were to get this going at your office. In residency, we had those professionals, but when you're trying to transfer people, always have the caregiver do it. Have the caregiver or the family member. Don't get into it yourself.
Real question.
Oh yeah.
Question. In terms of medications, you said you get the physician to prescribe it. How do you communicate that to the physician?
Yeah, I have a slide on this, but basically at every new patient appointment, we get the physician's name, their phone number, and their hospital information. And you can find them, and you have to have a fax machine because most hospitals are still kind of based on faxes. You have to send a fax asking them for a medical consult. And I'll go into a bit more detail about that because I think it's very important. Many of us, and me before residency, I had a blanket form called medical clearance, which basically said, is this patient cleared for dental? And then it would come back and say, yes. I'm like, okay, that doesn't really help me much. So what we do now is we ask specific questions that, hey, this patient told me that their A1C was 8.1. What can we do to manage that so that I can do like full quart of extractions? Or we will ask like specific questions. They have dementia and I'm having trouble with compliance. What can you offer to this patient before the dental appointment that will help them enable dental treatment? So we ask them very specific questions and they have to be answered. And I have a very good team. They will make sure that these medical consults are back before we see them. And they will also ask for a new patient appointment, because sometimes for a new patient appointment, you want to make sure that it's worth your time. You don't want to see patients that are quite obviously not ready for you to even look at them. So sometimes you need to do these medical consults even before the patient has seen you physically. So my team will ask that question when they are, on the phone with them, that, hey, how are they at the hairdresser, for example? How do they do with blood work? Do they have to be held down? Or do they allow someone to prick them and get blood? We have like these intake questions that give us a lot of ideas. And I do have like a slide on that.
And the physicians release that to you even though you haven't seen the patient yet?
Huh?
The physician releases that information to you even though you haven't seen the patient yet?
Physicians may not prescribe medication. They may not prescribe medication unless you have seen them, but they will release that information because the release comes from the patient.
Right.
The patient has to give them permission to release that information to you. So they will usually do that. And in fact, I've actually had physicians who, for like a limited exam, because I've gone for patients to just do their extractions because they've had teeth that are bothering them and they have to be extracted that day. So we have actually had physicians prescribe meds prior that I go in, do the extractions, and then the patient is fine. So they will do that sometimes. Oh yeah, I know. 100%. Kaiser is the only hospital system, I know it's being recorded, that is really, really hard to get in because it's like such a closed system. It's impossible sometimes. But what I've found is sometimes just calling their office will help. Sometimes you have to call. And I've had us play like, phone tag for a few days, but then most doctors will have a physician assistant who's answering their phone calls for them. You tell them that, I'm available from 12 to 2 on Friday. Please have the doctor call me because I'm seeing my patient on Monday. You have to call me back. And then usual physicians they're so nice. They're just like us. They will they will pick up the phone, give you a call, and tell you what you need to do. So when your faxes and paperwork stuff is not working, just pick up the phone and just call. And sometimes in the past, I used to have to dedicate like a half day every week to actually set aside time for these phone calls. But now my team does most of it because now they're trained and they know what the wording is. Yeah, but I've had that same issue, so not alone. Yeah.
This was about the transfer, transfers, because we get patients also in wheelchairs, and we have our chairs that they need to use. Is there like something solid that we can tell the caregiver why we cannot transfer the patient? Because they get upset.
Yeah.
Caregivers get upset and say, "Well, why can't you do it?" I'm like, we just don't.
Oh, you can tell them that we are not trained to do that. You just tell them, just be very honest, like, we are not trained to do that. I do not want to risk any injury to the patient. I do not want them to fall or have an issue, because we are just not trained to do that. The team we had at Highland Hospital, they're actually extremely well trained, and they're like, they're strong. They know how to do it because there's a certain way of doing it. And even though me and my team, like, we have done the training, I still don't feel comfortable doing it, because what I've noticed is many of my patients they're getting bigger. Their BMIs are 30, 32, 35. My lead assistant and I are tiny. We can't get into this because we can also risk injury to ourselves. So my priority is always to protect my team. I don't want them to get into any issues. So I try not to transfer them, and just be honest, we're not trained to do it. Yeah. You're in the dental field, you're trained to be, in radiology, like, you're taking x-rays, you're a technician, so that's kind of your specialty. Yeah.
Do you have the caregiver sign something in terms of liability, or no? You just tell them.
Oh, for transferring?
Yeah.
No, most caregivers know how to transfer. They know how to do it. They get everything. So typically it's like a cloth, and they slip the cloth under the patient, and it's a 2-person transfer. 2 people do it. Or if there's a wheelchair here and a dental chair here, and you can kind of YouTube this, but the patient, if they're able to get up by themselves, they will lean on them, and then you twist, and then you put them on the dental chair. So they kind of sit on the dental chair, and then you lift their legs and put them. But there's techniques like that. Most physiotherapists know how to do it because this is their patient population. So they are very trained to do this. But we did not learn this in dental school. This is not our field. So I would say, be safe and try not to get into it. Great question. Any other questions? Yeah.
Some of the dental equipment, the headrests actually come out and you can turn it around. Sometimes you feel the react to it. So still,
Yeah,
the headrest.
that is true. And you can even lift the arm of the wheelchair as well as lift the arm for the dental chair if they can just move in, scoot inside. So if patients with disabilities are also driving their car, then they are a great candidate for just doing a self-transfer. They would be safe because when they're driving their cars, that's what they're doing. They're getting inside by themselves. Awesome. All right, so we'll kind of try to go through these medical comorbidities a little quickly because we still have a few things to cover. But GERD, many of us are seeing patients with GERD pretty regularly in practice. And I used to kind of not worry so much about GERD, but I do now because if you notice, most patients with GERD are also pretty overweight or they have obesity. This is an aspiration risk. So consider that if you start to send these patients out to a sedation center or operating room dentistry, 50% of patients who are pregnant also have GERD, right? Third trimester, it's pretty bad. So pretty much the same protocol you use for patients with GERD. You kind of seat them a little upright. You don't want them leaning too far back because everything like comes up. You might also, of course, be the first person to discover this patient has acid reflux because you see it in their teeth, you see it in the mouth. So that you know already. I won't go into detail there. Chronic kidney disease. Some of you are already seeing patients with some form of chronic kidney disease, type 1, 2, 3. I'll focus a little bit on the more extreme version of kidney disease, which is dialysis. Maybe some of you are seeing these patients in office, but typically when patients are receiving dialysis, their kidneys are really not working or doing much. That's why they're going in for dialysis. What we know from dialysis is that the bleeding risk is high, right? So you're worried about doing extractions and basically extensive forms of treatment. There have been lots of different studies about when to time treatment. There are some studies that say you should go the day before dialysis, some say after. In my experience, and from what I've done in residency, we always saw the day after, and it's been fine. So the day after dialysis is fine. The day of dialysis, even if patients want to come in for treatment, I highly doubt they will. It's a very exhausting process. Dialysis is like a 3 to 4 hour appointment. They are exhausted. They don't want to do anything, let alone drive to a dental office for treatment. The only reason I've seen patients on the day off is if it's like a denture try-in or a partial try-in, which takes like a few minutes. So that they are fine with. So that's okay. But that's kind of my spiel on dialysis. Hypertension and cardiac disease. I always see patients with hypertension and cardiac disease in the afternoons. I never ever see them in the morning because there have been lots of studies that actually show patients are more likely to develop a stroke in the morning, 6 a.m. to 12 p.m. That is, it's called a morning surge because your blood pressure is always running so high. And imagine if they're coming for a 9 a.m. appointment, their blood pressure is high, they're running late, they forgot their breakfast, they forgot their meds. It's a mess. Just see them in the afternoon, you will be fine. So I almost always see patients of hypertension or any kind of cardiac disease in the afternoon. They're a lot more chill. Fall risk, we kind of went over that already, but just remember that a lot of our female patients can be very, very frail. So be extra careful when they are being transferred or when they're being seen in your operatories, because the fall risk there is quite high. Diabetes, there's a couple of things I want to touch on in diabetes. Of course, there's oral hypoglycemic drugs, which most of us have seen in practice. There's insulin-dependent diabetes, and then there's the GLP-1s, which is like the latest like fad, right? Unfortunately, what I've noticed is from the time I moved to the US to now, the number of patients I see on insulin is actually quite high now. I'm originally from India, and in India, if you don't know, it's like the diabetic capital of the world. We have a lot of diabetic patients in India who are on insulin. Unfortunately, the trend is catching up in the US. It's not a good one. So learning how to manage that is pretty key. Most patients who are on insulin or have any kind of diabetes, I see them in the morning. So it's just kind of the opposite of the hypertension. Why? Because their blood sugar tends to be more stable in the morning. Most patients on insulin are also checking their fasting blood sugar in the morning. So they will know right away if it's fine or not. Or they will tell you that, oh, my fasting was like 93, it's okay, or whatever, right? As you proceed down the day, their blood sugar has spiked up and down because of all of the meals that they have had. So it's more likely to be erratic. So try and see them in the morning. Patients on GLP-1s, do any of you kind of know how GLP-1s work? Have some idea? So GLP-1s basically cause delayed gastric emptying. They sit in your tummy for longer. So it basically makes your tummy is processing the food out a little later. So it tells your brain that you're still full, and so you are less likely to eat more often. That's basically how GLP-1s work. The big risk for patients on GLP-1s is if you're seeing them for sedation in your office. So whether you're just doing oral conscious sedation, just giving them a benzo, or doing IV, I would still encourage you all to follow the same protocol. technically they should be fasting before they get any kind of sedation in office, because there's always an aspiration risk. And some patients might slip from mild or mild conscious sedation to moderate conscious sedation. You may not know. Everyone reacts differently, right? Even if you give them like a 0.125 milligram of a benzo. So just kind of keep that in mind when you're seeing patients with GLP-1s. Their GLP-1 might need to be modified or maybe stopped the day of sedation if you end up seeing them for that. If you're not doing a lot of sedation in office, don't worry about it too much. Parkinson's is actually not that common of a condition, but in the last 2 lectures I've given, I've always had a question on Parkinson's, so I figured I'll just add this here. Patients with Parkinson's are typically on a combination of medication. If you're probably familiar, it's carbidopa, levodopa. Unfortunately, there's not much you can do to help patients with Parkinson's cooperate more. They have muscle tremors. You can't really do much about it. You can't give them muscle relaxants for it. The only thing that I've seen that works is nitrous, which you can offer in your office and make them very comfortable. And also try and focus on short appointments if you can. I had, before my last baby, one of the last patients I saw was for a number 15 crown on a patient with Parkinson's. It was terrible. It was a nightmare trying to do the number 15. But we did it anyway, and then that's when I decided I'm not going to see them on my last day before mat leave, because that's just not a good way to go. Any questions about conditions I mentioned? Okay, all right. I know it's a lot. So these are some of my tips. If you want to kind of learn more, or the medical side of stuff kind of interests you, I really love this podcast, Curbside Internal Medicine Podcast. It's hosted by 2 physicians. It's great. Just talks about pathophysiology of different conditions. If you have time on your commute, it's a good one. Hippocrates and UpToDate are apps that you can have on your phone for checking drug interactions. So most of us use this in residency. I still have the app since then. So sometimes if I see a drug that I don't recognize, I plug it in and you can find out what interactions it may have. ADSA app, you should have this. It's by the American Society for Dental Anesthesiologists. It's completely free. It gives you all of the medical emergency flows. Remember, in a real medical emergency, most of us are not thinking. Like you're kind of panicked, right? Our brains stop working. So having that flow on the app is really, really nice. And what I use it for most, me and my assistants, is for anesthetic dosage. So sometimes, when you're trying to do a lot of extractions or treatment, you're just using a lot of carpules and not realizing, and you're not doing the math of how many have I added, have I gone too far. So my assistant, for any extractions, she will basically check the BMI of the patient. She'll ask them what is their height and their weight. She'll plug in the BMI, and with the BMI, it will tell you, okay, you can use this much septo, this much carbo, or lido. I'll give you the max, and she writes it down on a piece of paper next to me. So that is there like for every extraction appointment, and it really, really helps. So, and of course, ChatGPT can help you write any medical questionnaire. If you plug in yours and you want it to be modified to add more questions, like some of the stuff we are talking about today, just do ChatGPT. You don't have to break your head over it. Okay, so case study 1, and this needs to be interactive. If you guys don't volunteer, I will ask you questions. But I had a patient who said very randomly, "Doc, I had a mini heart attack 2 weeks ago." And I was like, "What?" And none of my assistants heard it because they were in the middle of preparing for treatment, like they were setting up stuff. So she mentioned it so casually. If I wasn't listening, I wouldn't even have heard what she said. So this is her brief kind of problem history. She's 69. We had already seen her for a recall in August. We were in the middle of doing some partials for her. Her crown came off on the upper left. So that's why we had gone in earlier. And she told us that she had had an end STEMI which is a non-ST elevation myocardial infarction. It's still a heart attack, but she kind of called it a mini attack. And she did not tell my scheduler that. So I just want you to think about these things as I present it to you, because I want you to pick out on red flags. The partial delivery is obviously contingent on the crown. So now that the crown has come off, the partial no longer sits. So we have to kind of do that process again. She lives alone, but she also has family that lives in another city in the Bay Area. So she lived in like Daly City, and I think her family lived in Hayward. So she has to cross the bridge, which takes an hour, right? And she was receiving home care services at that other family home, not at her home, after her NSTEMI. For the dental appointment, however, she came back to her place. The reason I mention this is because I do portable dentistry, so I see patients at their home setting, and she thought it was okay for her to come back to her home just for the dental visit. So these are just x-rays. You can see that probably something was going on with 14 a while ago. It does have like an open margin, but we decided, I don't want to do anything unless it's like an active problem. But of course, as luck would have it, it came off, and now the buildup came off with it, and so we need to do that process again. So this is what her medical history looks like. It's just a snapshot. There's lots of stuff over here. She has chronic kidney disease. She's taking lots and lots of medication. She's taking Eliquis. She's on insulin. Her A1C is 8.4 despite of the insulin. She's had the NSTEMI before in 2024, and now she's had one again in 2025. And she takes antibiotics before dental appointments because of her valvular disease. So there's a lot of stuff going on, right? Okay. So this on top is kind of a sample of what we wrote to her physician, that, hey, we know that she's had an NSTEMI. We know that 2 stents were placed. When is the best time to proceed with dental treatment? She needs to get a crown done, right? And we will not use any epi, and we'll continue to, monitor her blood pressure, blah, blah, blah. Do you think that this is enough? Would you have done something different? What are some other red flags that you see in the situation? Yes.
Even the anesthetic itself could react with this.
Yeah, it can. It definitely can. Yeah. So you're saying that, that question is probably not enough, right? Yeah. Okay. Any other question or concern that you've had in this whole like experiment of her being alone at home less than a month after her NSTEMI? Okay. So in general, I think the biggest thing that I learned from this patient was the fact that she didn't actually understand that she had a heart attack and how serious it was, because she chose to travel alone and be alone at her home when really she should be under 24/7 supervision with family around, right? That's usually like the first 3 to 6 months after any kind of cardiac arrest. You want to be with someone at all times. And it's not a safe time for any kind of dental treatment. So I had to actually spend 15-20 minutes explaining that to her, because sometimes our physicians don't have the time and are not able to go over it. So you have to be the person who's doing that. So that was one of the things that I was most concerned with, because I realized that we will leave the house in 10 minutes to go see another patient, but she's still going to be alone at home. What if something happens? What if she has an arrest and she's on the floor? There's no one there to help her. That was my main concern. And of course, the crown and everything is fine, but it's not just kind of the epi-containing anesthetic, but really what also kind of worries me is her 8.4, her blood glucose still kind of being very high, despite of being on insulin. So really, if she's on insulin, her sugar should be better controlled. It really needs to be in a range of 5 to 6. And if she's still having A1C that is 8, that means she needs to be on a better regimen. She needs to increase her dosage. And of course, that is only a suggestion we can make, but we can actually write that out in a medical consult and say, 8.4 is a little high for me to proceed safely with dental treatment. I need for it to be better controlled. Can we do that in the next few months? And then usually physicians will say yes, and they will take care of it because it's just increasing the dosage usually. This is another fun case study. We'll see who can be Sherlock Holmes here, but very simple, just nice guy, talk, I want to get my life on track. I need to get my teeth done. And I basically just need to get a job, and I can't get a job with my teeth looking like this. And I'll show you what his teeth look like. So these are kind of his x-rays from a year ago. You can tell there's a lot of cavities, right? High caries risk. Anteriors, there's a lot of darkness in there. There's some big cavities, posteriors. What you can also notice is that there's pretty recent extraction sockets. So he's recently gone somewhere, had teeth pulled. So very active source of active stage of decay. And then these are what his intraoral photos look like. We always take pictures for every patient, not necessarily for education, it's just for our records. But of course, when patients see their photos, they have questions about it, and they see what it looks like. And you can see this is very problematic, right? Cavities in the anteriors, like right over there, and the gums are like not looking happy at all. When you see that red margin, this is like a nightmare for orthodontists probably, right? It looks like terrible, but it's concerning when you see these kinds of cavities. So he was unemployed. He lived with his mom. Recently went to another dentist to get those teeth pulled, and then came to see us. Medical history within normal limits, right? So he's the patient who doesn't have a medical history, basically, takes no medications, and it's like the no-no-nos being crossed out, You've all seen those patients. So do you think something is missing from the story? Possible?
Drug use?
Very good thinking. Yes, so he wasn't on drugs, but he was a chronic alcoholic. And that is something, we would not have gathered as easily, because the time of day that we visited him was in the afternoon, which was actually a really good time of day for him. But subsequently, when we saw him in the mornings, he would be extremely tired because he would have a binge drinking session the night before. And with drinking, it would also be with eating. And what is the biggest issue with patients that are on drug use, like recreational drugs or chronic alcoholics, from a dental perspective? Like, what are we most worried about? Sorry? Yes, no, very high caries risk for sure, but they're like impossible to numb. They're so hard to numb. Their tolerance is so high. I used to doubt myself, like every time I'm trying to numb him, like, what am I doing wrong? Like, my eye is just not working. I need to go back to dental school. But no, it's really because his nerves are just shot out. I can't do anything. Like, even like, Dr. Malamed can't do anything in this situation. What we realize is we just need to see him in the afternoons and not in the mornings. And we had to lean on his uncle and his family members to make sure he gets enough rest and sleep the night before, ideally not drink, so that he's better in, when we go in for our treatment. That's the most important thing that we saw, because apart from that, there was nothing else. And remember, most of these patients will not reveal recreational drug use or alcohol history unless you specifically ask for it. So luckily, my lead assistant, my work wife, she's very good at asking these questions. She basically kind of figured out from the uncle who was there, what is the reason for his oral hygiene being this way, and that's when he told us. Okay. So these are just some ideas for what you could use in practice starting tomorrow or Monday. I usually don't use a whole lot of cartoons or TV. Cartoons or television in my practice are more of a distraction rather than a behavior influence. Like, it doesn't really influence behavior change in my experience. It just basically distracts them from what's happening. It can work in a pediatric patient for an anesthetic, but in an adult, it doesn't work as well. So we usually don't use that. We just want them to focus on the treatment and kind of just focus on those little moments. If you see a patient who is a flight risk, for example, they just want to run, that's a red flag situation. You do not want to see patients who just want to run out of the dental chair. You will see some of these patients, so just know that that's not what we want to do. Radiograph and intraoral photography. If we see a patient who's potentially not as compliant, we always start taking photos first because photos are so easy. We use mouthwash, but you can use any product on the market that's, like a USB device. Just click, click, click. If they allow us to take photos, then we add a little bit more to that and do x-rays.
Send them to see dental.
Or send them to see dental. Yes, of course. And I'll go over stabilization rules in one of the other slides. So I have only one or two more case studies, but we're very close. This is one of my favorite patients. He, a 48-year-old heavy-set male with IDD, living at home with mom, not had a cleaning in years. Okay, so this is a very typical patient, adult patient with IDD that you might see. We were actually not able to get anything on this patient on the first visit. He just allowed like these random photos that we somehow took. But looking at it, you can tell right away there is some serious perio stuff going on and that he probably needs an SRP. But what I could also see in this picture is that he didn't have like too many red flags in his mouth. Like he didn't have any like grossly infected teeth that need to be extracted or something like that, like immediately. So the first visit, he just does not sit in the chair for a long time. He will get up and run to the sink to spit or use a cup because he just did not like people being in his mouth. Obviously, he just did not like that. And he's a big man. So when he like gets up and moves, we all have to back away. So this is something to remember. This can happen in any of our dental practices. Safety first. And mom just says, this is the way he is. He does this for everything. This is why we haven't seen him at like a dentist. We haven't taken him to a dental appointment. So if you can tell, like, this is not very helpful information, but in some ways it is helpful because you know that this is his behavior pattern, right? So how do you proceed? Imagine this is a patient in your operatory right now. You have an hour dedicated to this patient. Mom is there, so you can ask her other questions. You have managed to take some photos. Are you going to start taking any x-rays? Do you stop? Do you think maybe I should do something else and try another time? What is your game plan? Remember, this patient is in your op. You have 1 hour to see him. Any thoughts? Do you want to try? No? He's in your operatory. You have to do something.
Getting him comfortable.
Yeah. So that's really good. That's helpful. You want to try and just get him comfortable and not do too much, right? So what we actually did was, I do this for almost all of my patients who are neurodiverse. And it might be because I have a toddler at home, but I always sing. And I always sing like the silly songs that I know. I'll sing the ABC song or the Wheels on the Bus or Twinkle, Twinkle, Little Star, because these songs almost everyone knows. Weirdly enough, when I sang the ABC song, he actually loved it. And then mom was like, oh my God, he loves this song. How did you know? And I said, I didn't know. I just started singing a song. And so my lead played it on her phone and kept it on repeat so I don't have to keep singing it. And when he heard that song, he started like singing along and he wasn't moving as much. So we at least controlled like his need to move all the time. So he was sitting there, and because of that, we finished taking photos, but at least we learned that important piece of advice that he likes the ABC song. Because mom was there, we asked her, hey, how do you get his hair cut? If it's a different hairdresser every time, does he allow them? Or does he allow blood work? And she said, no, he doesn't allow blood work. His doctor always gives him like a midazolam or something, like a benzodiazepine, and that helps him calm down. So we're like, great, let's get oral conscious sedation going for the next appointment. And that's what we did. So the second appointment, we gave him OCS, we played the ABC song. He at least allowed us to do x-rays, and we did a toothbrush prophy, but we didn't do anything else. And then, but at that appointment, I realized that he actually did need some extractions because he has such like advanced stage period disease. And so for the third appointment, we just upped his dosage for OCS, and he was a lot more compliant. So it took us almost 3 to 4 visits, but we actually managed to finish an SRP. We did extractions, and he did great. So this can happen. Some of your patients will surprise you, but they might do really well. So play music they love. If you have dimmable lights, this really helps. Giving patients stuffed toys to hold might seem silly, but it actually works a lot. My lead will always give a stuffed toy to every patient who's coming in for an extraction or getting like anesthetic. She just asks it in the sweetest way so they don't feel judged. Like, do you want to hold something? This is a unicorn. You can hold it. And some patients will say, yes, I do want to hold something. So it kind of works. And consistency, which you can offer in your private practice. These are some of the physical supports that you could use. I'll be very honest and say that I don't use them much at all. I've only used them in residency. I like to keep a picture here for you to see what is possibly a tool you could have in your toolbox. But remember, when you use any of this kind of stuff, you need a consent form signed. Okay. There are also models that come that help you actually show it to a patient or their family member before you offer it to patients so that they can see what it looks like. And this is called a rainbow wrap. It's actually very comfortable. I would encourage you to at least try sitting in one. You feel very cozy, like a cocoon. And it's not meant to be used every time. It's for the first visit till the patient understands that I need to be still. That's the goal for dental treatment. I need to be still and not move my hands around, move my feet around. But apart from residency, I have never used this. I always like to be more conservative, and I will try 5 times before I give up on someone. So I will do like repetition of visits and behavior change before I have to use any of this. These are tools I offer to every caregiver. This is a 3-sided toothbrush. It's available on Amazon. That's a mouth prop, open wide. It's called open wide, which most of you probably know. Caregivers should be using this because with a regular toothbrush, you cannot brush someone's teeth. You really should be using a 3-sided toothbrush so you can get the lingual parts as well. So sometimes just showing them this will help them. And I do want to talk a little bit about materials. The goal is always to offer excellent dentistry and excellent materials. The reason being, if you have to redo dentistry, that's going to be very frustrating, not just for you, but for the patient and their family as well. Isolation is really key here. I always try to use 3M or Ivoclar for restorations, like especially posterior restorations. And in my hands, Panavia works really well for cements. The portable equipment that I get is from Aseptico. It's a company called Aseptico. There's a few other companies, but we have only used Aseptico and like their products. If you are starting to see patients with special healthcare needs in your office and you want to see them, say, in the waiting room because they are not fitting into the operatory, having a portable setup from Aseptico will really help you. It basically looks like a trolley, like a luggage trolley, but when you open it, suction comes out and there's a drill and everything. So you can work with that. We use STF a lot with some of our patients. And there's something called a stabilizing board. We call it a surfboard, but it basically sits behind a wheelchair and you can basically make sure that the patient's head stays still for long durations of treatment. Because if you notice, most wheelchairs cut off at the shoulder. So the patient's head kind of wobbles around and it's really hard for them to hold it. So having like a big board behind them will help them just keep it in place and they're more comfortable. So we use that and we get it from a company called Specialized Care Company, which pretty much focuses exclusively on patients with special healthcare needs. So they're pretty good. And we already talked about Stella Life and toothpaste and everything. So we won't go into detail with that. the treatment planning section is very similar to what I discussed in medical considerations anyway, but we do use oral conscious sedation, IV sedation when needed. And I have not had to make a hospital referral in a long time, but that is always an option. Just remember that patients with dementia are not candidates for any kind of benzodiazepine. So you have to rely on nitrous and keep just short appointments. And as a rule, I never numb on the first visit. That's pretty traumatic for most patients. They will never come back to you because they will be really, really afraid. So that's, I think, my last case study that I'll discuss with you guys in a bit. So we went over this briefly when Sarah asked the question about what are you guys asking and what the medical consultation kind of looks like. But when you have that first new patient appointment, that's when you're trying to get all of the information possible. How is this patient's behavior? How do we prepare? You need to get their PCP info, contact info. Who is the decision maker? We should be confirming with paperwork who the power of attorney is. Whether they're in a guardianship or a conservatorship, we should be making sure of these situations before we give out healthcare information. And what are the visit goals? Is it problem focused or comprehensive? If you have a ability to do teledentistry, then that's fantastic because you can do a teledentistry appointment with the patient to see what their behavior is like, so you know exactly how to prepare. That's what we did for residency. I don't do that in private practice because it just doesn't work with our schedule as much. But if you have that ability and you do it anyway, that's great. Medical consults for any patients receiving sedation or being referred to the hospital, we always get a full H&P. H&P is a history and physical. So it's basically like 10, 12 pages on the patient, and every single system is being broken down, like endocrine, cardiac, respiratory, everything. So you find out all of this information about patients that they will never be able to tell you because no one knows that much in detail about their own health. I talked about how we do a half day sometimes for phone consultations, but of course my schedule has become too busy for me to do that anymore, so my scheduling team does that now. And remember that if you're doing oral conscious sedation or IV sedation of any kind in your office, we should be asking for more questions. So you want to find out whether they are good candidates for any kind of sedation to rule out obstructive sleep apnea or aspiration risks. Those are pretty big hazards, and they will be a little bit increased in this patient population. There are specific codes, dental codes, that you can utilize in practice for billing. Whether insurance pays for them or not is out of my control, but you can definitely put the code in. So there's a behavior management code called D9920 that we use all the time, and we always have this note. So this is literally it's like a template that I have on CareStack, and I just fill out how much time I needed for the appointment, whether they did well, was it successful, not successful, did we make some modifications. You have to put all of that information in so that insurance also is aware of what you did. We did talk a little bit about sedation already, so I don't have to harp too much on this, but just remember, a lot of patients get turned away from the hospital, and you do not want to be that provider where that patient goes to the hospital and comes back, because they are going to be very frustrated with you. Okay, so this is my last case, and again, we will go over it together. But she was super, super sweet. She was like, "Doc, I did a really stupid thing. I listened to my friends." And you know, that's the start of a great story, right? So before I show you her photos, this is what her medical history looks like. My handwriting is terrible, so I'll kind of go over it. But she's a 74-year-old female. She has occipital neuralgia and myelomalacia. These are pretty intense conditions that I can go into. And she's the patient who I mentioned was on the DNR status. She told me that she's allergic to all kinds of local anesthetics, but carbocaine is okay. And she's only taking Tylenol and Taradol, right, which is a pain medication. And she last took alendronate, which is a bisphosphonate, about 10 plus years ago, and that was via IV. So lots of things going on here. Just I'll just talk a little bit about number 2 and 3 because maybe it's new to you. But basically, her spinal cord is extremely fragile, very, 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 very fragile. Because her spinal cord is so fragile, she can't really be moved a whole lot. She needs to move herself. She has a 24/7 caregiver, and she is on a lot of pain medication. She's trying to cut back, is what she told me, right? But Taradol is a very strong pain medication because of her occipital neuralgia, which is here. She just has like almost constant pain, which is why she was on a DNR status. She's just like, doc, I don't want to continue this life if I don't need to. That's why I've done my advanced health directive and I'll be done when I'm done. That was kind of what she told me. So what was the stupid thing she did? So does anyone have any idea what's going on in this photo? If you just kind of see this, any guesses?
Her amalgam's
Her amalgam's changed?
changed?
No.
No. What was those then?
What is this? What is this stuff, right? Let's see if anyone else, maybe the orthodontist in this room can figure out, or maybe Vax. Good thought. Exactly. So it's a homemade DIY. See, I knew orthodontists would pick that out. It's a homemade DIY veneer system. I saw the box and I was just like, oh my God. So what she did was she used it twice and it was not enough. It did not fill the gaps that she was trying to fill, right? And you can see the gaps here. There's like a couple of teeth broken. She has like 3 teeth in the anteriors that are broken down. So obviously she's not a candidate for a true veneer, right? But she used the material twice. It was not enough, and so she put a lot of it, and then that's what happened. And I saw her a week after she had done that, and she was miserable. Like she was like almost crying, and she's just like, I did such a stupid thing, you know. I need to get this out. Like she was just desperate to have anything be done. So you're seeing this patient in your operatory, okay? And you see all of this, and now just think about her medical history and figure out what you're going to do. So what are you guys going to do? If you see this patient in your op, she needs to get that out. Are you feeling pretty comfortable going ahead, getting started? Or do you want to send a medical consult? Or are you worried about her occipital neuralgia and her myelomalacia and you want to do something? Yeah.
She took alendronate how many years ago?
10 years ago.
No, strap. See that, right? So,
Do you know?
I think
Good question.
6 years though, or how many?
10 years. She took it 10 years ago.
Oh,
Do you know what is the half-life for alendronate? Okay, we'll go over it. No, but I love your what you're thinking. It's actually 10 years.
Oh, yes.
Yeah. It's 10 years. Half-life is 10 years.
Is that Boniva?
It's Fosamax. Yeah.
It's
So
Fosamax,
yeah.
which is like-
Yeah. So alendronate. I'll go over that in a bit and what we do for patients with that. Yeah.
Was it IV?
She was taking IV.
Oh, okay, that's
She's
fine.
taking IV. Correct. So we have handled the osteoporosis part. What else is a possible concern?
First, you have to get that out of her mouth.
First, you have to get it out of the mouth. Are you going to do it today? No? Yes? Okay. So there's so many things, right, with this patient. There's like so much stuff going on. When we saw her, we actually took it out. It's not hard to remove. It's basically all of this is plastic, kind of acrylic-y thing. I had to just make like some cuts through it, and then the whole thing popped out. So it took me like maybe 10-15 minutes, but just a few cuts, it all came out. She was crying because she was so happy that it was out, but she was not able to brush or do anything. So she was very happy we got it out. These extractions, so alendronate, So there's oral bisphosphonates and there's IV bisphosphonates. We all know that IV bisphosphonates are a little bit more complicated than oral bisphosphonates. But the half-life of most bisphosphonates is 10 years. So is it like practical to wait like almost 20 years to see her for extractions? It's not super practical. Um, in the past, like AAOMS, like the oral and maxillofacial surgery group, had actually advised us to wait, like do a 6-month drug holiday. So what we would do is, if patients are already on the drug, they would stop it for 6 months, they would get their teeth pulled and then go back to it. But this patient took it 10 years ago. So at 10 years, her risk versus benefit is kind of questionable. So I told her that, hey, the half-life of this thing is 10 years. You took it 10 years ago. These teeth don't look great. If we take them out, I can make you a partial. She was like, okay, I understand. So when you discuss these risks of, okay, maybe it's going to take a little bit time to heal, longer than expected, but we will try to do it very atraumatically. We will be very careful. We will start like mouth rinses right away. You should be okay. All of this reassurance kind of helped her, and then we took those teeth out so that we can make her a partial. Because remember, her most important thing, remember we talked about the 5 M's. So what mattered to her most was really to be able to FaceTime with her grandkids. And she's like, my grandkids get very scared when I smile and talk because I have all of these holes in my mouth, which is really sad. So I was like, we can take these teeth out and make you a partial. We will take it out the day we put the partial in. So you at least have like something, and it's not like a life-changing activity for you. So we did that. So that's what I do for patients with bisphosphonate. You have to look at their risk profile. So bisphosphonates check if they have an active cancer. If they have active cancer, then their risk goes a little bit more higher. They're harder to heal. If they're not in cancer, if they're under remission, it's mostly going to be okay. Patients with bisphosphonate also tend to have GERD, but again, this patient will never ever be a candidate for sedation of any kind. You could try to refer her to any place in the world. No one will take her because of her spinal cord. No anesthesiologist is going to be convinced to do this case. So she needs to be seen in a portable setting or in a dental practice. But if you were to see her in a dental practice, she would just need a lot of accommodations. Because remember, her spinal cord is very, very fragile. She comes on a wheelchair and she would come with her caregiver. So if you were in this situation, seeing her in the office, you could probably use either her waiting room, your waiting room, if your ops are really small, or see her in the op, but be seated on the wheelchair. Yeah. Any other questions or thoughts about this case? It's a very unusual one.
So how do you lean them back if their wheelchair doesn't recline? Then how did you treat her?
I did not lean her back at all. So she was just on her bed. Remember, I do portable dentistry, so I went to her room, into her house, and she kind of moved herself. Her bed actually her bed has the ability to actually sit up a little bit, but she was just leaning against the wall, and she moved herself. She did not need anybody else to move her. And as long as she's comfortable, I am comfortable. Because ergonomically, just remember that for the next 30, 40 minutes, maybe you will be a little bit uncomfortable, but you will get her out of pain, and then it'll be done. Because most likely when you see these patients, it's just going to be like one patient in your string of 15 patients in the day. So you're not breaking your back too much. But you will make her day, if you are able to take care of her, because most people are going to be worried when they see somebody like her with their medical history. Yeah. Okay. So that actually, I'm actually at the very end of the presentation. This is just about emergency protocol. We already talked about the ADSA app, which is great. And in our office, we do monthly simulations for medical emergencies. We come up with a case, and then we kind of problem solve as to who is going to be the leader and who is like the number 2 in charge or the number 3 in charge. And we go over the case together of what we would do. The ones listed in red are the most common situations we have seen in practice, like syncope and panic attacks, but really the other ones are pretty rare. But yeah, this is kind of my summary. Start with safety. Remember what I kind of talked about, transfers and stuff. Take care of yourselves, take care of your team and the patient. Prioritize predictability. If you have a assistant or a hygienist in your office who has the heart for this kind of stuff, make them the lead. So whenever you see patients with special healthcare needs on your schedule, have them get involved, let them be engaged. They would love that kind of leadership. So that's kind of what we do in our office too. Use short, successful visits. If the goal is just like a toothbrush prophy or just intraoral photos and the patient does well, they will cooperate for more treatment the next time. So just kind of keep that in mind. And strong medical collaboration. We talk to physicians all the time. The more you get familiar with their processes, the more they will understand about dentistry. So it will help, we will help each other. And when in doubt, just call. And yeah, every patient is different. So just remember, individualized care is the most important thing. Yeah, and thank you so much for joining me. I know this was a big presentation. If you have questions, please stay back and ask, but thank you so much.
Don't forget our next meeting will be Thursday, January 29th. That'll start next year. We'll hopefully have a child.
I will. Definitely. Definitely. Another one. Yeah.